Good morning. My name is Lutzky. I'm the Director of Cutaneous Oncology at Sylvester Comprehensive Cancer Center in Miami, Florida. I will be talking today about treatments for advanced uveal melanoma and try to convince you that there is indeed light at the end of the tunnel. First, we're going to talk about some generalities about uveal melanoma. We will also discuss some of our work at Sylvester Comprehensive Cancer Center and the current clinical trials that are available for patients with advanced uveal melanoma. Uveal melanoma is the most common cancer of the eye, but it is only 5% of all melanomas, and there are only 2,000 new cases a year, 2,000 too many, I should say, in 8,000 cases globally. There are some risk factors that are associated with the development of uveal melanoma. They include having moles in the back of the eye, a condition called melanocytosis, which is characterized by the position of the pigment melanin in different parts of the body, and also some familial syndromes. There are a result of some abnormalities in mutations in certain genes, like the BAP1 gene and the NF1 gene. It's important to point out that a history of melanoma of the skin or cutaneous melanoma does not necessarily increase the risk for uveal melanoma. About 50% of the patients that are diagnosed with uveal melanoma will eventually develop metastatic disease. And that metastatic disease, half of the time, seems to be confined to the liver. There are different parts of the eye where uveal melanoma can start. The most common is the choroid, noted here. The choroid is the part where the retina is, and it's in the back of the eye. This can usually not be seen externally. When melanoma starts in the ciliary body, noted here, or in the iris, sometimes you can actually see the tumor when looking at the eye, as noted in these pictures here. Both melanomas, the cutaneous and the uveal, derive from the same cell type. The melanocyte is the cell that produces the pigment melanin, but they're two different diseases. For one, uveal melanoma, as mentioned, is much less common. Second, we pretty much know that cutaneous melanoma is related to exposure to the sun or to ultraviolet radiation. We don't really know what the cause of uveal melanoma is. The mutations that we see in the genes of cutaneous melanoma tumors and uveal melanoma tumors are different, as noted here. The way you manage it is different. Uveal melanoma is usually managed by radiation to the eye, and sometimes when it's very extensive, by taking out the eye, the so-called enucleation. And cutaneous melanoma is managed differently, is managed by taking out the initial melanoma and checking the lymph nodes. The way that we assess risk of metastasis is different. And as previously mentioned, where the first metastasis occur is also different. Uveal melanoma tends to be the liver, and cutaneous melanoma tends to be the lymph nodes or the lung, the bones, but also the liver and brain at a later stage. And unfortunately, treatment for cutaneous melanoma is much better, has evolved a lot more than treatment for advanced uveal melanoma. So how do we stage? What is staging? Staging is a method that will look at certain factors of the disease and decide which patients have a higher risk for the disease to progress. So here are just two or three of the common staging systems that have been out there for uveal melanoma. The problem is that some of these are complicated, some of these require molecular data, but the prognostic tool that we use in the United States, and it's become the standard of care, is the so-called gene expression profile. And it is the only tool that has been prospectively validated. That means it has been put to trial in a large randomized trial with lots of patients, and it has been proven to be accurate. So a gene expression profile is checking the status of different genes in the uveal melanoma tumor. This profile looks at 15 different genes, and depending on how these genes are expressed, it creates a class 1 and a class 2. Class 1 tumors have a very good prognosis. And as you can see here, this is looking at percentage of patients that don't develop metastases, and this is time in months. You can see the patients that have class 1 tumors do very, very well, with the vast majority never developing metastasis. On the other hand, patients with class 2 may develop metastasis at a significant rate over 5 or so years, to the point that at 5 years, almost 70% of the patients with class 2 have developed metastatic disease. This is another further refinement of the system, and this was just recently described by the same group that created this gene expression profile, looking at what's called PRAME. PRAME is a protein that, if it's present in the tumor, it worsens the prognosis for every class. So for class 1, it makes it worse. For class 2, it makes it worse. And I'm just mentioning that because you might be seeing PRAME mentioned in some of the tests that are done now for patients with uveal melanoma. So why do we need to know that? We need to know what the risk is, because that determines what we do with the patient. If somebody has a class 1 that is low risk, or a class 1B that's medium risk, or a class 2 which is high risk, we may want to monitor these patients differently. We want to monitor patients very intensely if they have a high risk, and we want to do the types of tests that are very precise to try to pick up the development of metastatic disease at an early stage, where it might be easier to treat and potentially cure that patient. I'm just briefly taking you back here to cutaneous melanoma, melanoma of the skin. These are the drugs that have been approved over the past decade for the treatment of cutaneous melanoma. You can see a really very prolific field. And this has resulted in an improvement in survival for advanced melanoma of the skin from 5% 10 years ago to 50% currently. And we are hoping to do better with that every year. Unfortunately, that's not the same case for patients with metastatic uveal melanoma. This is a study of almost 1,000 patients with uveal melanoma. And you can see here that the median survival of patients with metastatic uveal melanoma is short of 12 months. That doesn't mean that everyone will live less than 12 months. It means that 50% or the median will be at 12 months, but the other 50 could do better, could do worse. It's important also to know that patients that have treatments that are directed to the liver, what's called liver-directed treatments, seem to do better. But that may be because patients that have disease localized to the liver would do better anyway, because the disease is not as widespread. So what is liver-directed therapy? We like to use liver-directed therapy when the disease is localized to the liver, or where there's very little disease outside of the liver. And there are different ways to do that. One is embolization. Embolization means that you plug the artery that feeds the tumor. And the way you do that, you go through the groin generally into the hepatic artery, which is the artery that feeds the liver. And from there, you find the artery that's feeding the tumor, and you throw in whatever gel film stuff that will clog the artery. And by doing that, you will deprive the tumor of blood. You could do that alone, which is called bland embolization, but most of these embolizations, additional things are added to this hepatic artery. Some are immunologic materials, some are chemotherapy, some are radiation containing materials like the Y90 or yttrium-90 microspheres. So these are little microspheres that have radiation in it, and you throw them into the artery that's feeding the tumor to kill the tumor. This is used quite frequently. Other things you can do is to go to the hepatic artery and just, instead of blocking it or embolizing it, you can just put chemotherapy through that. And another technique that has been studied a lot is hepatic perfusion. Here, it's not just the hepatic artery, you are perfusing or giving chemotherapy to the entire liver. So there are different methods to separate the circulation of the liver from the rest of the body. And then you give high doses of chemotherapy to the liver only. And that actually has shown some success. Another option is taking out the tumor from the liver. That applies to a very small number of cases because a lot of the times there's more than one lesion. And many times you go in thinking that there is one lesion and you find many. So for a small number of patients, surgical resection may be a good option. And the other thing that can be done that's liver director is ablation. Ablation means killing the tumor, and you can kill the tumor directly by different ways. You can put a probe in the tumor and put microwaves or cold or heat, or you can also ablate specific lesions with stereotactic radiosurgery, or more recently with more targeted proton beam therapy. So all these things have been done and are used, and some are more appropriate for some cases and some for others. But so there are lots of options there in terms of liver-directed therapy. So there are some clinical trials looking at different ways to do liver-directed therapy. I mentioned this one before is the hepatic perfusion is giving chemotherapy to the entire liver using a special catheter called Delcath. This is actually approved in England already, and it may at some point be approved in the United States. This is a study in which the radioactive microspheres, yttrium, were given into the tumor via the hepatic artery, but also patients got a combination of ipilimumab and nivolumab, which is combination immunotherapy systemically. The study has ended, and there was some toxicity with the combination, so the authors are planning another study using a different schedule. You can use also immunotherapy combined with immunoembolization. This is being done by the group led by Dr. Sato at Thomas Jefferson in Philadelphia. PV10 chemoablation, again, is along the same lines. PV10 is also called rose bengal. It's an immune active drug that's being given directly into the tumor in combination with chemotherapy. There's a Scandinavian trial called Scandium, which uses hepatic perfusion. Also, this is kind of similar to this percutaneous perfusion trial noted here. And there are other trials that are currently ongoing, have just started, or are already approved patients, and they include infusing viruses, other immune activating agents, such as something called TLR9 agonists, in different combinations directly into the tumors of patients via the hepatic artery for patients that have liver confined disease or mostly liver confined disease. So let's jump into other forms of treatment for uveal melanoma. And here I'm referring to a more widespread involvement, liver plus some other part of the body, usually the bones or the lungs or the soft tissues. And what you're looking at here is a diagram of a uveal melanoma cell. This is the outer membrane. And here represented are all the different pathways that lead to the proliferation or to the multiplication of these cells. And it's amazing that in a relatively short period of time, we have actually identified a lot of these pathways and a lot of the points that can be intervened with to stop the proliferation of uveal melanoma cells. And I'm showing here, with the arrows, these are trials that have been done to interfere with the different paths of this large pathway. And unfortunately, a lot of these trials have not shown good response rates, but more recently, some trials have actually shown significant shrinkage of tumors, significant response rates, particularly some trials that are combining drugs that hit the pathway into different areas. So here are some selected targeted therapy trials for patients with metastatic uveal melanoma. There's this trial by Dr. Carvajal at Columbia with this drug, selumetinib. This drug hits this target MEK, and let me just go back here for a second. MEK is right here in the pathway. There's another drug that hits PKC or protein kinase C, and that's up the stream here. Niraparib is a drug that hits PARP, which is a complex of proteins that repairs DNA, and for a lot of reasons that would take too long to explain here, inhibiting these enzymes that repair DNA may actually help to kill uveal melanoma cells. And then there are the epigenetic modifiers. So these are drugs that work in the way the information in the DNA of the metastatic uveal melanoma cells is translated, and interfering with that translation of information sometimes leads to death of the uveal melanoma cells. So there is this trial from this company called Plexicon, and we actually just started this trial from this company called Foghorn. So there are a number of trials like that. And then there's a trial targeting FAK. FAK is in this area here. It's not shown here, but FAK is active in this area. And this trial ID using this drug IDE 196, which a combination of drugs that hits in two parts of the pathway. So the other way to treat uveal melanoma and melanoma in general, and actually a lot of tumors in general, is to try to increase the activity of the immune cells to attack the tumor. And there's been a lot of study in what kinds of immune environment are propitious to kill tumors. And uveal melanoma actually falls into this category, which is called immunologically ignorant, which means there aren't enough immune cells around the tumor to induce a strong immune response. So a lot of the clinical trials are trying to change that environment from immunologically ignorant to sort of this. It's infiltrated with immune cells. So what are the current immunotherapies that are available for uveal melanoma? Essentially, checkpoint inhibitor therapy. So checkpoint inhibitors are molecules such as CTLA4 or PD-1. I'm sure you've heard those names before. And there's been a number of trials with agents that are inhibiting PD-1, and these agents are nivolumab and pembrolizumab, but the response rates are low, only about 5 to 8%. And survivals, the median survivals there in the 5.2 to 10.3 months. When you combine an inhibitor to PD-1 with an inhibitor to CTLA-4, like ipilimumab and nivolumab, it looks like the response rates are a little higher, 12 to 18%, and the overall survival may improve to around a median of 19 months, which seems significant, although there hasn't been head-to-head comparison between single agent and ipi-nivo. There is a feeling that the combination may be more active. Here, there are a number of immunotherapy trials for uveal melanoma, and these are just some selected trials that I wanted to discuss. There is this trial using something called arginine deaminase that deprives the tumor from arginine, and that makes the tumor more susceptible to the immune system. This trial, we're going to talk a little bit more in detail. This is the drug called IMCGP100 or tebentafusp. This was a trial in which patients were assigned to receive this drug versus investigator choice. And this was actually a positive trial. R means that the trial has already been reported. There are trials at MD Anderson looking at giving T lymphocytes in combination with immunotherapy to patients with uveal melanoma. There are other trials giving just tumor infiltrating lymphocytes or Tcell cells, which is a form of immune treatment without modification to uveal melanoma trials. This is another checkpoint, a new checkpoint that's being investigated, and it includes patients with uveal melanoma. And this trial was actually just reported, I believe, a couple of weeks ago. And this is using one of these DNA interfering agents in combination with a PD-1 pembrolizumab to treat melanoma of the eye, and it did show a 14% response rate with not a lot of toxicity. So it is an interesting avenue to pursue. And the nivolumab plus relatlimab trial that is open at our center, and I will talk a little bit more about that later. So this is the trial that I just mentioned with the DNA interfering agency or epigenetic therapy, and it showed a response rate of 14%. So I expect that we're going to see more trials, a combination of immunotherapy and these epigenetic drugs. So going into a little bit of our work at University of Miami. This is data from Dr. Harbour's lab, in particular Michael Durante, who did all this work as a PhD, MD student in his lab. And he looked at the immune microenvironment. That means the immunologic cells that are around the uveal melanoma tumors. And he looked at almost 60,000 cells. They have the ability to look at these cells individually. So he, among those 60,000 cells, he was able to separate the different types of cells into the different types of immunologic cells. And then when he looked into more detail, he went to look for these checkpoints in these immune cells. And what he found is that, remember, we talked about PD-1, we talked about CTLA-4. There's another checkpoint called LAG-3. In melanoma of the skin, in cutaneous melanoma, PD-1 is very highly expressed in the immune cells that are around the tumor, and so is CTLA-4. LAG-3 is very little expressed in a melanoma, cutaneous melanoma T cells. However, in uveal melanoma, we see the reverse. We are seeing now that these LAG-3 checkpoints are expressed a lot more than the PD-1 and CTLA-4 in the T cells that are surrounding the uveal melanoma tumors. So that was novel. That is a novel finding. It has actually been reproduced in another lab in Sweden that showed exactly the same thing. So we think it is real. Now, there are drugs that target LAG-3 that can inhibit LAG-3, and one such drug is a drug called relatlimab. So this finding in the lab led to the clinical trial we are now conducting at Sylvester, which is a combination of nivolumab, which hits PD-1 and has independent activity in uveal melanoma, with this drug relatlimab, which blocks LAG-3. So patients with metastatic uveal melanoma that have been previously untreated with immunotherapy they are screened, and then they're treated for up to 2 years with a combination of nivolumab and relatlimab. And we follow these patients, as mentioned, for 2 years. We assess their response rates, their side effect profile. We also in addition to checking patients for response to treatment and for side effects, we are doing a number of what we call correlative studies, drawing blood in patients and looking at other samples to try to understand exactly what's happening when we treat patients with these drugs and find even better ways to block these pathways. The new kid on the block, and actually with good news, is this drug that is a Tcell redirector called tebentafusp. So what is a Tcell redirector? A Tcell redirector is a molecule like this one. It's created in the lab. And what it does, it connects the cancer cell with the T cell. Remember, the T cells are the immune cells that kill the cancer cells. So these molecules, they will bind on one side to a specific protein or peptide in the cancer cell. And on the other side, they will attract the T cells. So as the T cells pass by the tumor cells, they'll become attracted to that molecule and they will bind, as noted here. And once there is binding on both sides, cancer cell and the T cell, the T cell will be activated and will kill the cancer cell. So it's a cool idea, and it was actually shown to work in a clinical trial. The problem here is that when you create these molecules, the peptide or the protein that they bind to in the cancer cell depends on what type of immune system the patient has. So certain proteins are only what we call expressed in certain types of immune systems. So this treatment was geared towards patients that have a specific kind of immune system called HLA-A2, which is about 40 to 45% of the general population. So these are the people that are expected to have a benefit from these drugs if they were to work, and indeed they do. This was the study of patients that had advanced melanoma, and remember, they had to have that type of immune system, HLA-A2 or 1. They should not have been previously treated, and they were at random assigned to receive the new drug, the Tcell redirector, tebentafusp, or the investigator choice. So at that time, the investigators could choose between dacarbazine, which is chemotherapy that has been used for uveal melanoma, but really doesn't work well at all, ipilimumab alone, or pembrolizumab alone. And the patients were randomized in a 2-to-1 fashion, which means twice as many patients were assigned to the tebentafusp than to investigator choice. And the endpoint of the trial, or the objective of the trial, was to look at survival, comparing people that got this versus the investigator choice. And this was just presented recently in a meeting, in a national meeting, international meeting, I should say, and it was just published in the New England Journal of Medicine last month. And the trial actually showed that at 1 year, 73% of the patients that had metastatic uveal melanoma and received tebentafusp were alive compared to 59% or 60%. So that was a significant improvement, and that will likely lead to this drug being approved in the United States. So here you can see this a little more clearly, 73% versus 59%. And here we're looking at the adverse events, meaning side effects. So in the group that received the tebentafusp had a few more side effects in general than the control group that received standard of care. And some of these side effects were significant, meaning grade 3 or 4. These are more severe side effects. And that's because the drug needs to be given in the hospital for the first 3 treatments. This drug is given on a weekly basis, and there are side effects that are listed here that can be severe. They can be lowering of the blood pressure, it can be severe rashes, they have some nausea, some shortness of breath. They are all treatable, and there were no deaths from toxicity in the study, but it does require some expertise to give this drug. And as I said, it needs to be given in the hospital for the first 3 treatments or the first 3 weeks. And these are the survival curves. So at the median survival is almost 2 years for this group that received tebentafusp compared to the control group that received standard of care treatment that was 16 months. So the drug is not expected to be approved until sometime early next year, and maybe February or March. But in the meantime, the sponsor, the company called Immunotherapy, has created an expanded access program for patients that have metastatic uveal melanoma and have this HLA-A2 type immune system. Differently from the original trial, patients to go on this program could have had any number of prior lines of therapy. Remember, in the original protocol, patients could not have received any treatment. But there is data from other studies suggesting that patients that have been treated with other types of treatment also respond well to this drug. So this is an option. At Sylvester, we have treated a couple of patients under this expanded access program. We did participate in the original trial. It is sometimes a complicated process to get that approved in individual institutions, but if you go on the tebentafusp website, they can probably tell you where is a place near you that this is available. I wanted to talk very quickly about adoptive transfer or tumor infiltrating lymphocytes. This is the so-called TIL. So TILs are immune cells that are in the tumor, but they're not killing the tumor. And they're not killing the tumor because there are other factors that are preventing the cells from killing the tumor. So the idea is you do surgery, take a piece of the tumor, take these tumor infiltrating lymphocytes and grow them outside of the body. And then you treat the patient with chemotherapy that will knock out all these inhibitory factors that are preventing the tumor infiltrating lymphocytes to work and give back the tumor infiltrating lymphocytes. So doing that, and that is not really new. This has been done, for the past 20 or 30 years. It started at the National Cancer Institute with Dr. Rosenberg, and it has been used mostly for melanomas of the skin, cutaneous melanoma, where it has a defined response rate. And that seems actually to be coming back in melanoma of the skin, as some recent trials show that patients that had progressed on everything had an almost 40% response when this was done. But this is the first and only study that I know of that has been published in melanoma of the eye, metastatic melanoma of the eye. And indeed, it shows, these were 21 patients, it shows like a 33% response rate in these patients. And here you see the amount of decrease. This is everything that goes down below zero as the percentage of shrinkage of the tumor. Some tumors really, this patient here, for example, had a complete disappearance of the tumors. And you know, whether the patients were refractory or resistant to prior checkpoint therapy or not, you know, they all seem to respond. So this trial is expanding. It's being done mostly at the University of Pittsburgh. There's some other trials also that are looking at tumor infiltrating lymphocytes, some that are unmodified, just taken from the tumor and grown outside the cell, but others that in which they take it from the cell and they modify to try to make them more targeted to have more of a killing effect. They're done in other institutions. Finally, I wanted to talk about adjuvant studies. What is an adjuvant trial? An adjuvant treatment is a treatment that you give to prevent or try to prevent or to delay someone who has a high risk of developing metastatic disease, like patients with class 2 uveal melanoma, from developing metastatic disease. And this has been studied for many years. There's a number of older trials that are not listed here that were all negative. Here we see some of the more modern trials, and unfortunately, some of those trials using chemotherapy, for example, and interferon, these have all been negative. So chemotherapy really to treat uveal melanoma, we know it doesn't work in the advanced setting, and we know it really doesn't work in the preventative setting. There are trials using some targeted therapy. This targeted therapy is targeting epigenetic mechanisms. We did this trial with Dr. Carvajal at Columbia, which was targeting this gene c-Met that looked good in the animal model, but it really didn't pin out when we did the trial. This trial with Dr. Sato is still accruing patients in Philadelphia. So this is an option if someone who has a high risk melanoma and doesn't want to just watch and wait and wants to do something more proactively, this is a good option. And here there are some immunotherapy trials, BCG, interferon. This does not work, so we know that these drugs don't work. There are some other types of treatment that were tried, but they were stopped because they couldn't accrue enough patients. And there is the trial that is combining ipilimumab and nivolumab, which I showed you has activity in more advanced disease, and that is actually a very interesting trial, but it has just completed accrual. So this is no longer an option. So very few really trials in the preventative setting that are available now for patients who are at high risk. And there's some liver-directed therapy adjuvant trials, but nothing here that looks interesting at all. I wanted to tell you a little bit about the work that has been done at Sylvester and at the Bascom Palmer Eye Institute. Again, Dr. Bill Harbour's group found that this epigenetic agent called physendistac inhibits the growth of uveal melanoma cells, and specifically the growth of BAP1 mutant. Now, I need to tell you what that means. Most of the patients that have class 2 melanoma have mutations in this gene called BAP1. They lose BAP1. And BAP1 is a protective gene So it's called a tumor suppressor gene. So if you lose it, you lose the gene, you lose its function, obviously you become more prone to developing melanoma, and that melanoma tends to be more aggressive. So most patients with class 2 are BAP1 mutants. So this drug inhibits the growth. Here is the growth without the drug. Here is the growth with the drug. Same thing here, same thing here. Now, this is a mouse model in which the BAP1 was not lost, it's not mutated. So you see, it doesn't work as well here. And when you look down here, there's little pieces of tumor. The bottom line are the ones that are the controls, and the top are the ones that use the physendistac. You can see that there is a significant decrease in the mutated lines that have BAP1, but not a lot of change in the ones that don't have BAP1. The bottom line, it does seem to be an active drug, at least in preclinical, in animal models, inhibiting the growth of uveal melanomas that have this mutation. So this drug was picked because of a very large screening process that was done at Dr. Harbour's lab. And I'm not really going to go over this, but basically to say that this was not just pulled out of nowhere. There are many, many drugs that were screened specifically for certain functions, such as inhibition of an enzyme called HDAC4. But we don't really need to get into that now, just to show you that was a long process to actually isolate this drug. And this finding has led us to put together an adjuvant study of this drug in high-risk uveal melanoma patients. So we're still working on this protocol. We don't expect this to be ready to go until sometime early next year, because there's still a lot of details that need to be worked out. But we are going to select people that have very high risk of metastatic disease, so people that have large tumors and people that have the gene expression profile class 2. They're going to go through appropriate screening, and then they will be treated for 1 year with this drug. It's an oral drug and will be given 3 times a week. And we're going to follow patients, and we'll see whether there is any indication that the drug is decreasing the development of metastatic disease in these patients. So last but not least, I wanted to talk to you about the Collaborative Ocular Oncology Group, also called COOG. So this is a collaboration, a group of 22 plus institutions that was initiated by ophthalmologists that see ocular tumors. That's why it's called Ocular Oncology Group. And this is the group actually that led to the prospective validation of the gene expression profile assay that separated groups in class 1 and class 2. They are very active. They're able to accrue very well. Over a 2-year period, they put 1,600 patients in trials. I mean, remember, there's 2,000 patients a year in the country. So in 2 years, they were able to enroll almost all the patients that are diagnosed in 1 year. So it's a very effective group. And now COOG has started a medical oncology committee, and we're going to use this power of reaching out throughout the United States to create clinical trials for patients that have metastatic and patients that have high-risk melanoma. And this is the executive committee, and this is the medical oncology committee that's constituted by Dr. Carvajal from Columbia, myself from Sylvester, and Dr. Sato from Thomas Jefferson in Philadelphia. And I thank you very much for your attention. And going back to the light at the end of the tunnel here, I just wanted to say that uveal melanoma is potentially fatal. It has been understudied, underfunded for many, many years, but there are a lot of recent interest and insights and understanding of the molecular and the biology of uveal melanoma that have led to a new generation of clinical trials hitting new targets. And some of them, as I showed you before with the benefits, have been successful. There are a lot of new collaborative groups, a lot of funding mechanisms now to look into this problem. And for all those reasons, I think there is indeed light at the end of the tunnel. Thank you very much for your attention today. And I'm sorry that I cannot be there personally. I'm actually flying at this time that you will be listening to this talk. I'll be happy to answer any questions via email. Thank you very much. Have a good day.